Hi, everybody. This is Artificial Intelligence and Cybersurgery Podcast. My name is Dr. Andrew Gumbs. I'm here with my co-host, Dr. Vincent Grasso.
Hi, Dr. Vincent Grasso here. I'm the social media director and director of strategy for the journal. You can find us at aisjournal.net. And I think this is our 9th podcast, right, Andrea?
Yeah, I'm losing count. I think that's about right. Yeah. And we're gonna introduce Dr. Scott Hanan, my brother-in-law, and my former partner since I moved to France. So Scott, can you remind me how you know Vincent?
Sure. But first, thanks for having me, gents, and happy Father's Day to everyone who's watching. Yeah, so Vincent and I actually, it's I guess a long story, but I know Vincent for a very long time. We were residents together way back when in New York City, and I actually know a relative of Vincent's who I met when I was a med student, even before that. So
we should also start because I forget that this is a podcast. Like, where are you working right now? Where did you do your training, and what's your field of interest?
So I guess the best way to describe me would be just a sort of old-fashioned bread and butter general surgeon at this point in my career. I started off training in New York City and then did a surgical oncology fellowship in Pittsburgh. And for a while I was doing surg-onc, general surgery, and also a lot of anterior spine surgery, and kind of segued from a private practice, a solo practitioner in New York, to a member of a large multi-specialty group practice in New Jersey, where I am currently. And at this point, I still do a little bit of spine approach, but mostly just general surgery at this time.
So I've really been kind of shocked by the different types of healthcare systems that we have in the United States and here now in France. And I was really COVID really revealed a lot of things, or at least, I was obviously across the ocean, but it seemed like the system in the United States had some issues. I don't know if you could kind of fill me in a little bit of what it was like to be working during COVID back in the beginning.
Sure. Well, first, as a general surgeon, I was still working to some extent, certainly not to the same extent as the critical care docs, infectious disease docs, anesthesiologists. Those people were really on the front lines. I was sort of a peripheral player, but I think you're 100% correct. Obviously, the pandemic was a major stressor to the system here. I don't know if the way our system is set up economically as opposed to yours, as a single payer made much difference. I think it was just the system was overwhelmed regardless of how constructed. But I guess the interesting thing for me at this point coming out of it is just the kind of, as we discussed in the lead-in, I was probably representative of a large portion of medicine many years ago, which was kind of a cottage industry, a lot of very small practices or solo practice people. And now in the US, medicine is really much more corporatized, right? Most of us work either, like me, for very large private groups that are either self-owned or owned by private equity, or you're a member of a staff that's owned by an institution. And now the very small practice or solo practice people, they're like unicorns almost, right? If they're real, if they're still out there, you're not going to find them that frequently, right?
Yeah, they're very, very rare. Yeah, very rare. I would actually hazard to say that there's many private practice surgeons in France as there are in the States at this point. There are quite a few private practice surgeons. The reality is that in France, at least, most people have a title at a public healthcare system, say they work 60% or 40% there, and the rest of the time they do private practice. So there's really this dual system, which I actually find it quite nice because you can kind of take care of people who need it, and then at the same time, you can take care of, yourself and your family to put it a very simple and honest way, which is a nice balance because you can help people that need it, but by the same token, you can make a living, which is I find would be a great model in the United States. And what I was really referring to with COVID, and I was wondering, it looked like in New York, places like New York and New Jersey, they did a very nice job of opening places up so people could get tested and people could get vaccines for free and all of that. But that system really wasn't in place. They kind of had to build it on the fly. That was the impression I got, at least from watching it on TV. Was that the case, or do you think people had the structure was already there and people were they knew exactly where to go and get screened and vaccines and things like that?
Oh, no. Yeah. I mean, I'd say you're correct. Most of it was probably more built on the fly. Obviously, some infrastructure is always in place, but testing and vaccines was each sort of area did it a little differently. We used our urgent care and we set up tents in our own facility parking lots for testing, and vaccines were available to staff as they came out, and mass vaccination centers were set up, as you said, sort of popped up depending on what facilities were setting them up. But yeah, a lot of that just sort of happened. It wasn't in place to begin with, that's for sure. The public health system in France had that already, I guess, as a public health system, right? Had
Oh,
that
of
ready
course.
to
I
go.
mean, you just show up in the emergency room, like boom, like it's not really a problem. Or most people already have a primary care doctor, so they just go to the primary care doctor. It's kind of it's already up in place. In the United States, I found even myself, I didn't really have a primary care doctor for most of my life in the United States. Over here, if you don't have a primary care doctor, you can't get a job. Like, you need your primary care doctor to sign off to get you a job.
Yeah.
It's kind of built into the system, like they're part of your life. Otherwise you can't function.
Right. Interesting.
It's just a different mentality.
It's a good point.
Vincent, what did you see in Chicago?
It's a good question. So I'm not doing surgery right now. I'm doing family practice 2 days a week in Newark. I was asked by a friend, Dr. Tom Ortiz, to help him when COVID hit out. And so I've been actively seeing patients during COVID and flying to Chicago every 2 weeks and doing stuff there. COVID decimated the inner city. Think about the hardships for the Medicaid community without COVID, right? If they've got chronic diseases and they've got, an early diagnosis of cancer, good luck trying to really navigate them through the system, right? Expeditiously to see a surgeon, maybe get chemo, whatever. It gets done. But COVID introduced all these extra hurdles. And so we have big problems in the inner city with now picking up things late. Mammograms were missed, pap smears were missed, things were missed. And all of a sudden there's an avalanche of people coming back into the system. And you've got to, logistically, it's crazy, right? Go schedule all that stuff. And, even the health staff, the MAs and the LPNs were hit hard. They had to either resign because they didn't have anybody to watch their kids. They didn't have good home care. All these things, it created an avalanche. So, I'm really excited to have Scott on. Scott's very modest. He also has an MBA, right? So remember we spoke, Andrew, last week with Dr. Freebay about physicians needing to learn technology and business so that they could be more valuable to their community, their business.
Absolutely.
And Scott went off during being a busy private surgeon, got his MBA. That created a different perspective, right, Scott, for now how you see the delivery of care with that business lens. It was different than before you had your MBA, right? If you could talk about that, I'm sure the audience is excited about that journey you went on for that extra, these extra skills that really are valuable.
Sure. Well, I also would say that Vincent played a big role in steering me towards that. So I had mentioned earlier, I had been in private practice in New York, and the landscape in New York was rapidly changing. Hospitals that I worked in were closing, referral patterns were changing, reimbursements were dropping, expenses were rising. And so, I could see the writing on the wall that something was going to need to change. And while I was thinking about where I was going to wind up and what I was going to do with my family, Vincent mentioned the MBA program, and I got in and started it, and it was very different as a physician. I guess the way we think about problems is maybe the best way to describe it is much more linear, right? You see a single patient, they have a set of problems, you deal with that set of problems, and you move on. But the way you think about issues in business is much more global. You're looking at problems from many different perspectives, and the way the whole problem solving algorithm is very different. And I found it very interesting. And I think at this point, as you said, it gives you a much different perspective in how medicine happens and how important the back end is, or the stuff that isn't touching patient care directly as a physician, but makes the entire process work. So yeah, I very much enjoyed it.
There was actually an article that was published in our journal by Gudrun Aspelund. She was actually a chief resident with me at Yale. She became a pediatric surgeon, then she worked at Columbia Presbyterian for a while. Yeah. And then she's originally from Iceland. She moved back to Iceland. She works for the Ministry of Health. And she started basically, and then very quickly COVID hit. And so she wrote a nice article about her experience using, the socialized healthcare system and using things like applications on the phone, using artificial intelligence to help track people and to navigate people. And they did a very nice job. And I wonder if during your MBA, they must have talked quite a bit about artificial intelligence also. I mean, there must have been some segment on that.
There was not any segment on artificial intelligence. Oh, no. Obviously, there were certainly we touched on technology, but not in depth. So most of my knowledge of AI is really through you guys and through Vincent understanding and keeping up on the projects that he started in Chicago. But yeah, that I think, listen, you're in charge of the journal. Vincent, I know, is very active in the field for many years. So you guys are at the tip of the spear. So how important technology and information services are to the practice of medicine. There's no doubt that artificial intelligence is going to become better and better, and is going to become more and more important with the delivery of healthcare. There's just no other way to manage all the information that we're juggling right now, right?
Yeah, but what I actually noticed during when I just finished my master's in AI, and we actually did a lot of business. That's why I'm sure you were taught AI. They probably just didn't format it in a way that you realized you were being taught, because I was actually surprised how much business I was taught in this AI masters. I mean, they go hand in hand, because you're looking at numbers, you're looking at new ways of interpreting information. You're looking at new ways, a different way of solving problems. You're not guessing, you're really looking at the entire picture, and AI is able to synthesize it for you almost the easiest way really is in a graphic way, so you can see solutions that to problems you didn't even know existed. So
Scott and I went through I went through the UMass Amherst program, and then Scott went through that as well, and one of the great classes in there that touches on this whole, let's talk about, business process reengineering. You can't introduce AI into workflows until you document the workflows and see how you'll change them, right? So even Andrew, you got really good now at, that business process mapping notation that we've been working on for the pancreatic preoperative stuff. So Scott, went through that whole boot camp of understanding the as-is model, right? How do you do preoperative workups now? How could AI change them? And they become then the to-be model. So, the MBA gives you that great foundation to actually be able to talk to and work with the business guys on solving some clinical technical problem, right? So massive foundational value. And then the trick is to actualize it, right? To take that credential and make it work for everyone. So it's an exciting time these next 3 years. I'm sure we all agree.
Yeah, no, definitely. Now, Vincent, you were with Scott in Manhattan, and then you went to Yale afterwards, or?
Yeah, so
Tell me
Scott was my chief resident. So you were 2 years ahead of me, Scott. I think we had actually, we were in a New York Medical College program that was based at Cabrini Hospital, and we rotated through various hospitals. And then when I was in my third year, when Scott was just leaving, we changed affiliations to Mount Sinai, and it became a Mount Sinai Manhattan General Surgery program. So we spent a couple of years there, and we're trained by some really interesting, very gifted surgeons, and a couple of them were Italians, a Florentine guy, a guy from Naples. They had sleight of hand, and they were really well trained. It was an interesting group of guys that had good hands, really good training, right, Scott? I mean, they were kind of. You see a lot of surgeons; they were pretty world class.
Yeah, I know exactly who you're talking about, and I know one recently died, and the other a few years ago, Dr. Daliana, Dr. Rossi, and being at a few places, having the opportunity to watch and work with many surgeons. These two gentlemen were really special. They were fabulous surgeons, fabulous. I've never seen anybody who comes close to Dr. Rossi. He was just wonderful to watch. He was the guy who saved Andy Warhol's life.
Oh, sorry. Repeat that.
Yeah.
So he's these two. Daliana was Rossi's chief resident, and before Andy Warhol was famous, when he was shot, he wound up clinically dead at Cabrini. And there was a recent story, I can't remember which magazine it was, but Rossi saved his life.
I saw it.
In Manhattan, in Cabrini, on 19th Street, came into the emergency room, shot through the chest. I don't remember if it was a pulmonary vein or pulmonary artery injury.
There was a movie about that. Did you see the movie?
So they brought him up to the operating room, and he repaired it off bypass and brought the guy back, and he lived. So as the story goes, and I don't think it's really urban myth, he was, like a homeless guy. Nobody knew who he was. He didn't have any money, and he gifted Rossi one of his originals, which Rossi, being an Italian, liked a lot of old art, thought it was terrible, and put it under his bed and almost threw it away many times. And then later in life discovered that he had, a multi-million-dollar original Andy Warhol under his bed.
Oh, that's crazy. So what's interesting about that story, because I saw the movie, I think it's called I Shot Andy Warhol.
Yes.
This woman shoots him, and so that's funny that I had no idea it was Cabrini. But anyway, he survived, and then years later, he ended up dying at Cornell. He had a problem with his
congestive heart failure after his gallbladder was taken out. Yeah, he was fluid overloaded and died.
Yeah. Oh, that's a crazy story.
They're great.
But as Scott said, we were really lucky. These guys were not very well-known surgeons, but they were spectacular.
But is this the guy who used to do Whipples in 3 hours, 2 hours? You said, is this the guy? Is that another guy?
I'm sure he did Whipples, but by the time, he was a bit older, so he mostly did lung stuff. He had done everything, and he was principally a vascular surgeon, and he still did some pulmonary by the time I met him. But yeah, he was probably doing all that stuff as a younger person. He was also he had trained when he left Italy. He went over to NYU, and so he was involved with all the big vascular surgeons, but because he was a foreign medical graduate, his name's not on anything. But he helped develop a lot of bypass grafting. They were going out and harvesting vein and trying to come up with things before, obviously, there was Gore-Tex or Dacron, and they were basically making operations up to try to solve peripheral vascular disease. And he was one of the guys doing a lot of the experiments. Interesting fellow. Interesting time. Different, a lot different than now. Not a whole lot of information services at your hands, right? You're just a pencil and paper, right?
That reminds me of Vivian. I can't remember his name. Dr. Vivian something.
Something the Lord made.
Yeah.
Awesome movie. True story. Great movie.
Where he invented basically cardiac surgery and I shouldn't say never, but
eventually, right
at the end of his career, got an honorary degree.
Right. There was, I think, as you said, there was a recent paper in one of the journals, again, petitioning, what is it, the Blaylock-Tussing procedure to add his name to the end of it, which I think, I don't know if it's officially recognized, but I think there's a big push to have his name added to the procedure at this point. But,
Luca Milone, Dr. Luca Milone might kill me that I'm going to say this on this podcast, but I'm going to say it anyway. He was my fellow when I was at Fox Chase Cancer Center, and he had to redo all of the USMLE board exams and all this stuff, and he finally got through everything, and he's a big robotic surgeon in Brooklyn right now. But before he had passed all of his boards, he was a fellow with me, and we were watching that movie about Johns Hopkins. Dr. Vivian, what's his full name?
I can't remember his last name now.
Anyway, we were watching it at the end.
Look it up.
I hate to ruin the movie for someone who hasn't seen it, but at the end, they're like in the halls of Johns Hopkins, and they have a painting of him like up with all the other professors. And it's so moving after you saw all that injustice that I had tears in my eyes, and I was actually a little bit embarrassed, and I turned to look at Luca because he's with me watching it, and I see just tears streaming down his face. Also,
Even when you rewatch it, you still have that emotion comes over you. I've seen that movie many times.
It reminds me of that story of that Italian doctor you told me, just like what he had to go through and still didn't get the credit he deserved. It's heartbreaking. So
the old days.
Vincent, I like, this is the part of the show when I ask you, how can AI solve all the social injustice we were just talking about?
I'll put this to you guys, because Scott did surgical oncology, and you guys are active surgeons. So in Chicago and in all of the inner cities, I have the numbers. I have the numbers of people that haven't had mammograms, pap smears, colonoscopies, PSA tests, right? Cancer screening. So if I told you I've got a database with 25,000 people in it that haven't had cancer screenings, and then you said, oh, let's separate them into mammograms, pap smears. So you got 25,000 people, and you stratify them based on the procedure they need: a mammogram, a pap smear. By the way, women they need both, right? So that's they need pap smear and mammograms, PSA tests, and colonoscopies. So who do you call first? Who you have a like some medical group, University of Chicago, you have a bunch of people, case managers, and they got to start making calls. Did you get your mammogram? Why not? Can I help you schedule it? How long does that take? So who do you call first? Who do you call second? Who do you call third? How long does it take to go through the list? And how do you stratify risk? Who do you call really first? The novice says, I would call the person that didn't get it, and the interval between the tests is the longest. They're waiting the most. I'll call them first. But that's not the right answer, right? The right answer is who has the most risk, and how do you stratify risk in 25,000 people? And who do you call first, and they don't answer? Do you call them back? So think about conversational AI, like we've talked about. First, you got to do the machine learning to figure out who has the highest risk, right? You work that out. Now you got to call them all. How do you make 25,000 phone calls in a week? Right. So this is the exciting part for us, because we're all, with our business and IT and clinical skills, these are the kind of problems that need to be solved. So go to Memorial, go to Fox Chase, you ask them the same question. After COVID, all these people that weren't screened because of COVID and they all stayed home, how are you approaching this set of people that have to be called and brought in and be screened? And how do you call them? What sequence do you call them in? And they'll all go, this is a problem, right? So these are, that's just one little example, right, of something cool that AI could be helping us with.
And when you say conversational AI, is that a fancy way of saying a chat box?
Well, a chatbot is a entry level, functional element of conversational AI, conversational computing, and the most sophisticated would be a massively human-looking, realistic avatar that has the perfect brain behind it. So that's the bookends, simple text chat bot versus a very evolved digital human. And there's everything in between. So that's why this is so cool, is chatbots work really well in some use cases. And some use cases you need to evolve it to a more sophisticated, piece. which is the art of AI, right? There's the, the technical piece, and then how do you actually construct it? And, that's why this is so exciting. And without a business and IT background, if you didn't do your master's in AI and we were having this conversation, it'd be a very different one for you, right?
Absolutely. No, absolutely.
Yeah.
I look at healthcare problems in a completely different way. And I find what AI can do fascinating, because I don't want to say I'm tired of impacting one person at a time, but you after something like COVID, you would like to impact communities, societies.
Sure.
on a bigger level. You can have more of an impact with solving a small little problem. You can save many more lives than a surgery. So
I have something for you to think about, because we got Scott on the phone on the call a little more. So, connecting the dots even more. My cousin Doug DePice in New Jersey is a very interesting, gifted artist, and he's boyhood friends with Dr. Antinori, right? They know each other since grammar school, and my cousin married Dr. Antinori's wife, so that's the connection to Dr. Antinori, and he was one of Scott's attendings when he was in medical school. So a cool thing could be the following: smoking is still a problem, right? They said, yep, they approached COVID with a very interesting stance, but you can still smoke. You can go buy cigarettes and blow smoke around. That's okay. So thoracic, the CAT scan with low resolutions for, lung cancer screening, right, is now you're allowed to do that, and it's reimbursed. Dr. Antinori is a thoracic surgeon in New Jersey. Scott's in New Jersey. We may be able to brainstorm together on how AI could help with cigarette cancer screening related issues as a project, right? He's a thoracic surgeon. We're all in New Jersey. That could be a really interesting, take, he was on episode 8, right, Dr. Antinori? So
Right.
Scott, maybe the three of us, me, you, and, the three of us should have another call with Dr. Antinori and talk about AI and lung cancer screening.
Sure.
He's in active practice. That could be a cool thing for us. What do you think about that?
On that note, guys, as you know, I gotta do a presentation in the Ukraine. So Scott, Vincent, it was a pleasure to see you guys. I think that would be great if we'll try to organize another podcast in the future with the 4 of us.
Sure.
That would be great. All right, guys.
Be my pleasure. Be my pleasure. Thank you very much, gents.
Thanks, Scott. Happy Father's Day.
Eye-opening.
Thanks, guys. Have a great rest of your day, and happy Father's Day, Scott.
Thanks, Andrea. Have a good one.
Take care, guys.
Bye-bye.
Ciao. Take care.
We're out.